Good morning, everyone. We are back live. This is, we are on March 25th, and we're looking at H 266, an act relating to health insurance coverage for hearing aids. We have with us first Representative Leslie Goldman, reporter from the House. Thank you for being here, Representative Goldman. And then we'll go through the bill with Jen Carvey, and after that, we'll hear from DFR Representative Assistant Attorney General Sebastian Arguendo. So we'll get a full picture of the bill, and then we'll be hopefully we'll be scheduling the bill for testimony next soon. So thanks for being here. Go ahead.
Representative Leslie Goldman, for the record. Pleasure to be here. I think we all know how important hearing is. We can certainly hear what's going on behind us with the drill, but we can also hear birds in the morning and bells tolling in the distance. We can hear each other talk, listening to laughter of children or nuance, people crying and how that evokes emotion. People with hearing loss can participate in the world in the same way that those with hearing intact can. And this bill tries to expand, or intends to expand, hearing aid coverage for those with hearing loss. It has three objects to ensure. First is to ensure continued coverage of hearing aids and related services in Vermont Medicaid. Vermont Medicaid currently does cover it, but this codifies it, for what's the better term. The second thing is to affirm ongoing efforts to make hearing aids and related services part of Vermont's benchmark plan, which I imagine DFR will talk to you about in depth, and to make hearing aids and related services more accessible to Vermont residents by requiring coverage in the large group health insurance plans, which currently they don't. These are the last remaining segments of the commercial health insurance market over which Vermont has any regulatory authority. Vermont SEA they have negotiated hearing aid coverage, which will start in July of 22. Teachers union, we did not touch because that's part of their, that'll be their negotiated agreement. So those are the three objects of the bill. The DFR analysis says that adding a hearing aid coverage with a limit of one per year every 3 years will add a range of impact of allowed costs from 0.5% to 0.9%. So it's pretty minimal.
Okay, thank you. That's very clear. Appreciate that. And just questions committee, I just will say that some of us on this committee have been introducing bills related to hearing aid access for a number of years. So, and as we talked with you folks in the House, we're really appreciative that we can work together to take this forward in some form. So thank you for your work. So questions?
Just a clarification, Representative Goldman. You talked about one hearing aid for your one set.
Yes.
Hearing aid. Okay. Just to make
One
sure.
per year, every 3 years.
Gotta get both of them.
Yeah. And the cost range is extreme.
Oh, yeah.
Yeah, for those of you, many thousands. And they're easy to lose, so that's a whole nother problem, unfortunately. But that's the limit that Medicaid does as well.
Okay. All right. Yes, the cost of hearing aids is fascinating. I've looked at that several years ago, and the markup can be just over the top. So
The total cost stuff is very
yes, yeah,
Right, we just learned about that.
yes, that's good. Okay. Any other questions? Go ahead.
Do you need to know?
I'm not sure I don't know about bills yet.
Okay.
I'm learning. I'm not sure if that's a roll.
Well, you're on the floor at 9:30, so.
That's not a roll call, that's what I'm here. Yeah,
They're calling you.
Okay, that's
Okay.
They've only been on the floor 5
So then I
minutes,
have a question.
Red on top too.
Pardon me?
Somebody was asking yesterday why the red was on top in finance. And other committees, the green's on top. Lights.
Huh.
I think the green used to be on top.
Can I ask a question?
Yes,
I just
please.
didn't want to hold you if you were, this may be a question for Jen, but I just am scrolling through and this would require Medicaid coverage, which you said Medicaid already does, but codifying that, and then the small insurance plans, the private insurance plans as well, but
On the exchange?
on the exchange?
Yeah, the individual market and the small group market.
Okay,
And that's what's going,
We
that's,
will discuss.
we will,
Yeah.
yeah,
Okay, all right, all right.
and that's what's
We'll hold
going through DFR and the essential health benefits process.
Okay.
So that's what.
This is the interpreter. Could I interrupt? One at a time is all I can interpret. If everybody's talking at the same time, it's gonna get lost. I'm sorry.
Yes, with apologies, Darla. We'll be-
No, thank you so much.
Yeah.
So one of the points of the bill is the, for the small group market and the individual market has to go through the essential health benefits process, which Jen can talk to you about in depth. But it is asking DFR for a report on where that process stands to CMS, because that it's gone through the Mount Care Board, the essential benefit DFR plan, and now it's sitting at CMS, and we're waiting to hear back for approval for plan year 2024.
okay.
So good. Yeah, we'll come back to that when we get to Jen. I
Yeah.
think that would be helpful, but, so what was the vote out of your committee on this bill?
Some people were there, it was 10-0-1, but
It was 911.
911.
911?
Oh, that's true, of course, 911, sorry about that.
Sounds like a public health safety line. Okay, and any, and the vote on the floor, was it a voice vote?
Voice vote,
Okay, all right, good. Good to hear.
and I think the voice vote was unanimous, except there was one, well, I can't say unanimous, there was one nay
One no.
on the
I
floor.
wonder if that was the same one.
It was, it was
Okay,
actually someone I was sitting next to, so I know that,
very interesting.
totally,
All right,
but not my story.
all right. Thank you. This has been terrific.
Thank you, this is my first time, so, thank you for that.
Well, we've seen you on Zoom and worked with you on Zoom.
That's
so
right.
Now it's nice to have you here in person. And so I'm sure we'll see you again.
Yeah, I look forward to it,
All
thank you.
right. Take care.
Yes.
Okay, Jen. Right.
Oh, good morning. Jennifer Carvey from the Office of Legislative Counsel. We are looking at H 266 as passed by the House. It is now entitled an act relating to health insurance coverage for hearing aids. And so I'll take you through the bill. I know you just got an overview from Representative Goldman as well. It starts out by expressing the purpose, which I think is kind of helpful because sometimes looking at the statutory language is less clear if you don't know what you're looking for. So it talks about the importance of hearing aids and the importance of all Vermonters having access to them, but many plans don't cover them. Vermont Medicaid currently does. Most of the plans offered in the commercial health insurance market do not. And as this committee knows, federal law prohibits or preempts the state from regulating the benefits provided through a lot of plans that cover Vermonters, more than half the population, including Medicare and self-funded employer plans, what some people call ERISA plans. So then it talks about last year's budget bill and the directive to the to the Department of Financial Regulation and others to look at Vermont's benchmark plan that establishes the essential health benefits for the qualified health plans offered through the exchange, and to come back with a recommendation about whether to request federal approval to change that plan to provide certain benefits. And one of those that has been of interest to this committee and the House committee and others was to look at specifically coverage for hearing aids. So on March 2nd, the Green Mountain Care Board voted to approve a recommendation from the Department of Vermont Health Access, DVA, to add coverage to the benchmark plan for up to one hearing aid per year every 3 years and an annual hearing exam. And so DVA is now pursuing a change to Vermont's benchmark plan with the federal government pursuant to a process that they have laid out at the federal level the earliest we could get that coverage to begin would be in the individual and small group market through a change to our benchmark plan would be January 2024. So the purpose of this bill, as it says, is to ensure continued coverage of hearing aids and related services in Vermont Medicaid. They are covered now. This just puts that in the statute as an ongoing requirement. It affirms the ongoing efforts to make hearing aids and related services part of Vermont's benchmark plan, and then it makes hearing aids and related services more accessible to Vermont residents by requiring coverage in large group health insurance plans. And this is the remaining segment of the commercial health insurance market that Vermont has regulatory authority over and that does not offer those plans, that benefit in their plans. Section 2 is the report that Representative Goldman was referring to, and this would have DEVA providing an update by November 1st to the Health Reform Oversight Committee regarding the status of the department's application to CMS to modify the essential health benefits in Vermont's benchmark plan to include hearing aids and related services beginning in plan year 2024. So again, this is to put hearing aid coverage into the individual and small group market plans. So the qualified health benefit plans offered through the exchange and reflective plans to the extent that those are offered as well. Section 3 is where we're adding the requirement on Medicaid coverage. So it's really just kind of a general description of what is already happening, but putting that requirement in statute. So it requires Vermont Medicaid to provide coverage for medically necessary hearing aids and audiology services when delivered by a healthcare professional practicing within the scope of their license, including audiologic examinations, hearing screenings, fitting of hearing aids, prescriptions for hearing aid batteries, and other services as defined by DEVA by rule. And these services that are listed here are currently in DEVA's hearing aid and audiology rule. Section 4 is the coverage requirement for the large group market. So it starts out by defining health insurance plan as a group health insurance policy or health benefit plan offered by one of the various insurer types. And then it says, and so this is different from the way we often do insurance mandate language. It's if we're talking about just group plans and we're carving out, so it does not include, as used in this section, a qualified health benefit plan or reflective health benefit plan. We're dealing with that through the benchmark plan amendment process. And it does not include a health plan offered by an intermunicipal insurance association to one or more entities providing educational services. So this is the VHI plans, the teacher and school employee plans. And it does not apply to policies or plans providing coverage for a specified disease or other limited benefit coverage. And this is kind of standard language that we do often have in our health insurance mandates. And this is saying if it's a particular type of plan that's just for limited benefit coverage, it doesn't have to have the full complement of otherwise required benefits. Or it's hospital insurance coverage, or there are certain types of coverage, and if you have questions about what those look like, DFR is probably a good one to ask. Then there's a definition of hearing aid, which is any small wearable electronic instrument or device designed and intended for the ear for the purpose of aiding or compensating for impaired human hearing, and any related parts, attachments, or accessories, including ear molds and associated remote microphones that pair with hearing aids to improve word comprehension in difficult listening situations in live or telecommunications settings. The term does not include cords, large audience assisted listening devices, such as those designed for auditoriums, or standalone listening devices that can function without a hearing aid. Hearing aid professional services, which gets a term that gets referred to in the statute, is the practice of fitting, selecting, dispensing, selling, or servicing hearing aids, or a combination, including evaluation for a hearing aid, fitting of a hearing aid, programming of a hearing aid repairs, follow-up adjustments, servicing and maintenance of a hearing aid, ear mold impressions, and auditory rehabilitation and training. And our final definition is hearing care professional, because there is language in here that says the coverage has to be done when services are provided by a hearing care professional. So that means an audiologist or hearing aid dispenser, physician, physician assistant, or advanced practice registered nurse working within that professional's scope of practice. So here's the coverage requirement. A health insurance plan, again, we're talking just now about large group plans, must cover the cost of a hearing aid for a health insurance plan shall cover the cost of a hearing aid for each ear and the associated hearing aid professional services when the hearing aid or aids are prescribed, fitted, and dispensed by a hearing care professional. The coverage must include hearing aid batteries when prescribed by a hearing care professional. That was something that House Healthcare specifically added. The coverage provided by a health plan for hearing aids and associated services shall be limited only by medical necessity. So that's kind of the scope of the coverage. But the subdivision 2 allows a covered individual to select a hearing aid that exceeds the limits in subdivision 1. So they can get something that is more than what is medically necessary and pay the additional cost. So the plan doesn't have to cover something that is more than what is medically necessary, but the patient may purchase up. The coverage required by this section shall not be subject to a deductible, co-payment, or co-insurance provision that is less favorable to the covered individual than the provisions that would apply generally to other non-primary care items and services under the plan. So you can't have a special higher co-pay or co-insurance requirement or deductible requirement just for hearing aids. And then it specifies that a covered individual who has exhausted all applicable internal review procedures provided by the plan will have the right, as they do under existing law, to an independent external review as set forth in our insurance statutes. Finally, we have the effective dates. So that coverage requirement for large group plans takes effect on January 1st and applies to all plans issued on and after January 1st, 2024. On such date as a health insurer offers, issues, or renews the plan, but in no event later than January 1st, 2025. That's our fairly standard insurance coverage requirement. Effective date provisions where it rolls out over the course of a year. Most of our plans now, I think, are effective on January 1st, but if they are not, it would take effect whenever that plan is issued, offered, or renewed during the course of 2024. And the remaining sections take effect on passage.
Okay.
May I ask a question? So the reason for the 2024 is because it takes a while to get CMS approval or get it included in?
So this would have the coverage requirement for the large group market taking effect at the same time as the coverage requirement for the individual and small group market. So yes, the reason for the 2024 for the individual and small group market is that that's CMS's timeline. If you're making a change to the benchmark plan, it's to take effect. So if it's approved in 2024, it's to take effect for coverage. I'm sorry, if it's approved in 2022, it's to take effect for coverage beginning in 2024.
Okay, that's just a standard.
That's their process. Yep. So the same, if it was next year, then it would be 2023 and 2025.
Okay. And I'm assuming we'll get testimony from other people about this, but the 1 every 3 years, is that seems like a long time that it might.
I will allow the other, I don't have background on that, but I know DFR, I believe that was part of their work and looking at the benchmark plan changes, and you can hear from others as well.
Great, thanks, Jen.
Any other questions?
Question for Joe.
I'm planning to be here with you.
All right. So thank you. And I'm sure we'll have questions as we go along, but it seems pretty clear. And actually, I do have a question. do you, Jen, from your perspective and Senator Cummings, your perspective, is there any thinking on your part that this bill would make a visit into finance? Because I know we did talk about this.
It affects the insurance markets.
Yeah. So once we've looked at it in here, we'll be looking at Medicaid a little bit, maybe some of the other policy issues, then we should relieve ourselves of the bill and send it down to finance.
Okay.
Or we can, either way, we can pass it out or we can do that. Okay, so Sebastian Arduengo is here from DFR. Sebastian, welcome.
Hi, good morning. Can you hear me?
Yes, perfectly. Thank you. Thanks for being here.
Great, thank you. For the record, Sebastian Arduengo testifying for the Department of Financial Regulation.
Do we have anything on our webpage from you about the bill?
No, I haven't submitted any written testimony. Since I'm going after Jen, I think the best approach for my testimony would just be to make myself available to answer questions about the benchmarking process or about the hearing aid benefit.
Okay, all right, let's do that. And then we'll see what else we might ask of you going forward. So thanks a lot. Go ahead.
I think he just wants us to ask him
Ask
questions.
questions.
What?
He wants us to ask questions.
You don't have prepared testimony, you just want us to ask you questions, is that right, Sebastian?
Yes.
That's correct. If there's an issue in the bill that the committee would like me to speak to, I'm prepared to speak to that, but I don't have anything in particular to add to Jen's walkthrough of the bill. What I can do is update you on where we are in the CMS process.
Yeah. Before you get there, what would be very helpful is for us to understand the report, the work that was done by the working group, and then the report that came out from that working group, and the recommendation then for adding this into the benchmark plan, which is, so maybe just a little bit about how we got to where we are with the bill, and
Sure.
then we can go to where we are with the CMS process. I think that'd be helpful.
Is that report on our,
I think we have it.
it's not up for today, though, it's.
Sebastian, what is the name of the report that was produced related to, that has the hearing aids in it? Do you know? If you don't know, that's okay, we'll find it, but it would be good to have it on our webpage.
I don't have that right in front of me, the exact title of the report, but I will follow up offline and get it posted to your committee's webpage. I believe it is already on House Healthcare's webpage, but I can work to coordinate to make sure it's more widely available.
Okay, Jen Carvey will access that for us. So our work here is unfortunately completely separate from what the House, so whatever they do, we don't have directly on our webpage. We have to work independently because we have less meeting time. So, but Jen will get the report for us and Aaron will post it. If you don't mind just talking a little bit about the history of how we got here, and then we'll go on to the CMS piece.
Sure. So last year, the department applied for a federal grant to look at updating the EHB benchmark. Under federal law, all plans in the individual and small group markets have to carry essential health benefits. These are defined by reference to a state benchmark plan that's supposed to have benefits in each of a number of categories that are set forth in federal law. The legislature, as part of this process, directed the department in conjunction with the Department of Vermont Health Access to look at a number of different benefits for inclusion in the benchmark plans. Hearing aids was one of them. We also looked at adult vision and dental. We also looked at infertility services. Over the summer, we met with stakeholders on all of these benefits, and for a number of reasons, we landed on hearing aids as the sole benefit for inclusion in an update to the benchmark plan. The reason that we did not choose any dental services, for instance, is that even though there's a great need for coverage of dental services under federal law, adult dental services cannot be included in the benchmark plan without state defrayal. So in other words, if we did include adult dental services in the plan, the state would have to pay for the increased cost of those services. Similarly with adult vision, even though there's a great need, federal law would require the state to pick up the additional cost of those services. With respect to infertility services, the state and our contract actuaries found that the cost of providing those services in an equitable way would be far beyond what we could accommodate in the benchmark plan, because if we included a robust and equitable infertility benefit, the new plan would be richer than the richest plan that had previously been offered in Vermont. So we settled on hearing aids as a benefit that could be offered that would provide a maximal impact to those individuals that needed the benefit, while not sort of breaking the bank, as it were, in terms of creating a plan that would be richer than plans that had been offered in Vermont before.
Okay.
And I think there was a comment about how we landed on the specific benefit configuration that the Green Mountain Care Board ended up approving. And that particular benefit configuration is based on what Medicaid had already been covering for Medicaid beneficiaries. So that was easy to take and price out using Vermont data. So as you all know, the Green Mountain Care Board approved adding hearing aids to the benchmark plans for plan year 2024. And we're now preparing an application to CMS for approval. And where we are with that is there are two tests that the new benchmark has to meet. First, it has to be typical. So it can't be more or less rich than plans that had been on the market previously. And second, it has to be, it can't be more generous or more rich than the richest plan that had been on the market previously. Our actuaries are satisfied that by adding the hearing aid benefit, we would not cross the generosity threshold. So in other words, the new benchmark plan would not be richer than the richest plan offered. But right now they are determining whether the new benefit would result in the plan being atypical, and they're currently doing an analysis vis-a-vis plans in the large group market, which have benefits that plans in the individual and small group market don't, like lifestyle pills and acupuncture benefits, to make sure that the new plan would not be atypical as far as how rich it is. Once that analysis is complete, we plan on having a public comment period of at least 2 weeks as required by CMS. So the new benchmark plan and all of our analysis with respect to typicality and generosity will be available on the department's website and also on DEVA's website. And we'll accept input from members of the public. And then we will have everything ready by the filing deadline set by CMS, which is the first Wednesday in May. This year it's May 4th.
Okay, Senator Hardy has a question.
Thank you, Madam Chair. Sebastian, your terminology of the richest plan, first of all, is that a technical term, or are you, are those your words? And second of all, what are the plans that you're comparing to specifically?
Yeah, that's a good question. So I use the word rich here to mean like in an actuarial sense, is plan A providing more benefits than plan B?
Okay.
It's a term of art that we use in this context to describe an actuarial process. So it's easier to say, is the new EHB plan richer than the most generous plan offered on the market before? And I think, could you repeat your second question?
So, sure. What are the comparisons? They're the plans that are available.
Oh, yes.
for people right now in Vermont on the small group or large group plans. Is that your comparison?
Yes. So for the generosity test, we could use any health plan offered in Vermont in plan year 2014, which is the last time we updated the benchmark. So for the generosity test, we compared the new EHB plan to the state employee health plan, which was at the time the richest health plan offered in Vermont in terms of the number of benefits. And for the typicality test, we are comparing the new AHB plan to plans in the large group market that have all of the benefits that plans in the individual and small group markets do, but typically they have riders for services like lifestyle drugs or acupuncture, which makes them slightly more rich than plans offered on the exchange.
So I'm looking at the report and it looks like page 4 of the report shows where some of the things you're talking about as it relates to federal rules. So what you're talking about is very much federally prescribed.
Yes.
Yeah, okay. Yeah, that will help us. Having the report will help us, so that's good. Other questions for Sebastian at this point? So in terms of going forward, we're looking at when May 4th comes around, Wednesday, and then what will be the process after that? So that's a CMS application, or is it, what are we talking about on May 4th?
Yes, on May 4th, we'll formally submit the new benchmark plan to CMS along with all of the application materials that are prescribed by federal regulation. We've already been in communication with CMS, particularly about the typicality test, and we don't anticipate any issues with what we've proposed. Our hope is that if there are any issues, we'll have an opportunity to review those with CMS over the summer. And we anticipate having a decision by the end of the year.
Okay, so by January of next year, we'll know that we have hearing aids in our.
That's right.
Terrific. Okay, that's really good. All right, anything else, committee? Any other questions that you have for Sebastian at this time?
Oh, one,
Go ahead.
Sebastian, I don't know, thank you, Madam Chair. I don't know if this is, would answer this, but the question I asked Jen Carby about the every 3 years, and is that a standard somewhere, or do you know how that was decided as the sort of timeline? Because I think it's different for classes, for example.
Yes. For the purposes of this benefit, we chose that as the basis for our actual study and the actual benefit that was approved by the Green Mountain Care Board, because it was the same benefit that Vermont Medicaid was using. So as far as why 3 years as opposed to 2, I would have to refer you to DIVA.
Okay. I will save my question for them. Thank you.
Okay, so yeah, we'll have Viva come in, and we'll also have some others come in, including the healthcare advocate as we go through this. Any other questions now for a clarification, information? We begin to get the picture. This is good. All right. Sebastian, thank you. We're so far ahead of our time. It's hard to believe. So I think everyone is on the committee is actually pretty excited to see this happening. I could speak for myself, but I think I can also speak for the committee as a whole, that we're really very excited to see that hearing aids will become a part of our benchmark planning and included officially now in Medicaid. So we'll be taking testimony from DEVA. We'll also be hearing from some of the other folks, maybe in the insurance world. But then, as I said earlier, the bill will take a little trip down to finance, so we have all of our I's dotted and our T's crossed. But I'm not thinking this bill is going to be a heavy lift for us. Okay. Any comments from committee members? So we're good. Okay. All right, thank you all. I think, Jen, let's just see if committee members have any questions further about the language. Why don't you come up and we'll just look at it really briefly.
I'm sorry, Madam Chair, can I ask Sebastian another question? I know we just.
Yeah, Sebastian, please don't go. There's another question for you.
My thinking was that I would stay on the line in case there were any questions.
Okay, well, there's one right now.
Okay. I don't know if you know this or DEVA, so you can tell me otherwise, but do you know, I know we don't as a state regulate them, but do you know how many ERISA plans cover hearing aids? Is that information you would have at all? Jen's shaking her head no, so.
No.
No, you don't know?
Yes, our visibility into ERISA plans is unfortunately very low, since there's a Supreme Court decision that preempts state reporting requirements. So more or less all we know is how many of these plans there are. We don't have a lot of visibility into the specific benefit configuration of each plan, and it is possible that some or most ERISA plans cover hearing aids as a benefit, but if you've seen one self-funded health benefit plan, you've seen one self-funded health benefit plan, because they're all so different.
You were so diplomatic. What about Medicare? Does Medicare cover hearing aids?
No.
Oh,
That's
no.
one of the big
Okay.
No.
problems.
Well, a qualified no. Original Medicare does not, but there are some Medicare Advantage plans that do.
Got it. Okay. Thank you very much. You're so diplomatic.
Thank you.
Okay, committee, why don't we just quickly with Jen, do you mind, I know you've just done it, but skipping over the findings piece and maybe going into, oh, I have the wrong bill up, that doesn't help.
Yeah, do you want me to just remind you what is in?
Yes, please, and do that now that we've heard more testimony, this would be very helpful.
So section 2 has the report coming back in by November 1st about how things are going with getting the federal government to approve the change to the benchmark plan to add hearing aid coverage. Section 3 puts in statute the requirement that Medicaid continue providing coverage for hearing aids and audiology services. And section 4 adds a requirement that large group health insurance plans in our commercially insured market include hearing aids as a covered benefit for coverage beginning in 2024.
Okay.
Okay, I have a question for Jen.
Yeah.
The list.
We're in a conversation.
Okay. The list in paragraph 3 on the bottom of page 4, evaluation, fitting, et cetera. Did the House get testimony from a hearing aid professional that told them this is a list that should be, where did the list come from?
No, I believe the list was in the bill as introduced, and I think it's consistent with language in some of the hearing aid insurance coverage requirements in other states, although it's been a while since I worked on the language and it has been introduced in previous years, so I could be misremembering that, but it was a predetermined list, and I don't believe they made changes to it.
We could get a professional audiologist or someone to come in if you felt that I'm gonna run this by a professional I know and see if there's anything that he suggests.
Yeah, it might be nice to have that testimony, just,
Yeah,
I don't know, if the House didn't do it, just to make sure we're.
I agree.
They did hear testimony from an audiologist. She didn't, I don't believe she spoke specifically to whether this was or was not a full list. And I don't remember her speaking directly to this. I think she was talking more about coverage issues,
Yeah.
but you could.
We could bring an audiologist in. In the meantime, I'll reach out to an ENT I know. So.
Because I also would like to ask them the 3-year question.
Yeah.
Like how much
Yeah.
hearing loss could,
Oh,
you know, I mean, I know with eyesight, your eyesight can change a lot. I'm assuming it's true with hearing,
You're
but I don't know.
yeah, you're absolutely right.
And I'm wondering if there's any kind of time period after the fitting of the hearing aid, you know, if it doesn't work, can you then?
Yes, it does include follow-up, adjustments, servicing, and maintenance of the
Okay.
hearing aid. So
Follow-up.
so if you need to go back in to have some adjustments made or something that is included.
Okay. Okay, so we'll run that by, try and get an audiologist in, and I will talk with an ENT expert on this, and see what we can get. And that'll be an easy conversation. I'll go home and talk to my husband.
Well, if you want to come and testify, because I would love to hear, I would love to hear.
That's a heavy lift. All right. What was the other, I know, as Sebastian was talking, and you just mentioned other states, do we have any idea of how many other states are providing this kind of coverage?
So I had done some work with a prior BLS clinician a few years ago, just looking at specifically at New England states. Again, this was, it's a little outdated now. But I do believe there are requirements for hearing aid coverage in insurance plans in most of the other states in our region. New York did not have one, I believe, New York and Vermont at the time. So as of, I guess this was just last year, not too long ago. So New York did not have a hearing aid coverage requirement. Maine, New Hampshire, Massachusetts, Connecticut, and Rhode Island all did.
They all do. And how consistent is this proposed legislation with what some of those states have done?
So Maine had required coverage of at least $3,000 per hearing aid every 3 years, every 36 months. New Hampshire was at least $1,500 per hearing aid every 60 months. Now, some of these, if they're part of their essential health benefits, they can't necessarily have a dollar limit on them, so they may have changed since the laws that I was looking at. Massachusetts was also we'll just go with time period. So Maine was every 36 months, New Hampshire every 60 months, so 5 years.
Whoa.
Massachusetts every 36 months, 3 years. Connecticut, 24 months, so 2 years. And Rhode Island every 3 years. So it's pretty consistent for the most part, one 2 year, 1 5 year.
The timing is interesting because, of course, Medicare isn't in this, but if your hearing begins to go, it could go 6 months, 1 year. I mean, it's just like, Okay, all right. So can we get that table or information?
Yes, but I need to
Not
update it.
now, not now.
Because there may be some, I don't want to provide either outdated information or if there's some of them at the time had been, for example, coverage only for children. And under the ACA, that's no longer allowed because it's discriminating on the basis of age. And so, as I understand from DFR, so yes, let me,
Okay, that'd be helpful.
And did the House get testimony on the number of Vermonters that this might impact?
I
Sort of the
believe they
need.
heard, yes, I believe they heard testimony. I don't recall what the numbers were or what the sources were. So I think, there's some that may just be, I would expect there's under-reporting because there may be people who haven't sought care because they knew they didn't have coverage for it.
Okay, right. What else? Anything else, Jeff? Sebastian, you have your hand up.
Yes, I just wanted to note that in our actuarial analysis, we found that approximately 0.1 to 0.2% of members in the individual and small group markets would utilize the hearing aid benefit.
So are the results of that analysis in the report?
Yes.
Okay, all right, that's helpful.
There's also one more thing I wanted to mention about section 4 of the bill, and this has to do with the defrayal requirement. I think as all of you know, if the state mandates a new benefit, there's a defrayal requirement, meaning that the state would have to pay for that benefit. The EHB benchmark process is sort of an exception to that rule. So to the extent that we are directing changes in the large group market to conform to the EHB requirement in the individual and small group market, we would just ask that those changes be limited in scope to what is required, what was approved by the Green Mountain Care Board and will be required in the EHB benchmark plan.
Okay, thank you. I'm gonna ask Jen to show us exactly where that is in section 4. Where is the defrayal?
It's not in here. So what Sebastian is saying is the reason that we have specifically carved out the qualified health benefit plans in the definition in section 4, in the definition of health insurance plan that this mandate applies to, is because if you were to include those plans or have it apply to health insurance plans generally, the state would be on the hook to pay the additional premium for all of the qualified health plans attributable to that new benefit, and that's the state defrayal piece. So in order to, so the benchmark plan revision process through the federal government is a way for us to change what's in our benchmark plan and get coverage of this benefit without the state defrayal requirement. And so that's why I think he's saying, if you're gonna, please don't make any changes that affect the individual and small group market unless you want the state to be on the hook to defray the cost.
Oh, okay.
Yes.
Yes.
Thank you, Jen.
So this,
That's it. Good. Yeah. Go ahead.
so by doing it this way, we avoid defrayal because we're doing it as part of the every decade benchmarking plan or whatever.
Well, it's not, it's right. You're taking I don't want to say advantage in a bad way, you are using an authorized federal process for making a change to the benchmark plan to include this benefit. That is the way to add the hearing aid benefit without state deferral.
Got it.
But it also is the reason you can't add a whole bunch of other things right now, or you will exceed the generosity test that I think Sebastian was talking to you about earlier, and then they wouldn't approve our changes.
Okay.
So if you want this benefit in the individual and small group market, your best path forward is changing the benchmark plan, and then you can accomplish the same result for the large group market by amending the statute as in this bill.
Got it. Okay.
Good, okay, that now is much clearer, I think. Helpful. Oh, any other questions?
We're losing quorum.
Yeah. Any other questions for Jen? Any other questions for Sebastian? Good, okay, so what I think we'll do then is we'll end this meeting, we'll go off our YouTube at this point. And then we'll have a goal of bringing some folks in so we can further understand the, some of the requirements that are in here about the hearing aids and timing and so on. So we're accomplishing our goal as a committee. We'll also talk a little bit more about benchmarking and coverage, but that we're going to leave some of that, of course, to finance. So it will be a joint effort, two committees working on it.